the national healthcare systems have called 911. And it's the fire service that's going to come and answer the call. I'm Dr. Gary Smith. I'm the Administrative Medical Director for a CMS grant that has been received by the City of Mesa Fire and Medical Department, the Superstition Fire and Medical District, as well as Mountain Vista Medical Center and A.T. Still University. And it's a wonderful opportunity that we have to speak about a community care initiative that we have been looking at for quite some time. We've been researching this for quite a while. And what we're looking to do with this, the CMS grant that we have received, a $12.5 million, will be paid out over the course of 3 years, is to help us to test a proven model, as we have had a proof of concept that has been developed over the past 2 years with the City of Mesa Fire and Medical Department. And this model is to take a look at the pre-hospital healthcare system while we improve efficiencies and demonstrate a cost savings, while we also improve the quality of patient care that is being received in the pre-hospital care setting. The City of Mesa responds with 21 ALS engine companies and 5 ALS ladders, along with 2 community paramedic units and 2 community care units, one of whom has an advanced practice provider, which is a nurse practitioner or a physician assistant, and the other that has a crisis counselor that is on that apparatus. The City of Mesa responds out of 20 fire stations and on approximately 56,000 calls annually, and 80% of those calls are for emergency medical services. And we've identified other subsets of those calls. For example, we have 11% of those calls that are primarily for behavioral health services, and another 25% of callers are those who have been within the hospital setting in the previous 30 days. And that has been a substantial number. Adding the two up, 36% of our calls are for those that have either been in hospital in the previous 30 days or are mental health patients. Hence, we can see that's a large volume of the calls that we are actually going on. An analysis takes a look at this as well a little bit further. Of that 56,000 calls, 45,000 of them being for medical services, and of those, the 45,000, we have approximately 10,000 of those are of a low acuity nature. When firefighters actually arrive on scene, it has been found that it's up to 40% of those callers are actually of a low acuity nature, whereas the initial dispatch is only at 25%. So we can see that we are making some improvements and changes in our emergency medical dispatch with the IQAs, or the questions that are being posed to the caller, and we're making some adjustments there to assist in a better decision from the dispatcher as to what types of units should be dispatched on each of those calls. We also have in place a community paramedic units, of which they're staffed currently with 1 Mesa Fire and Medical Department captain paramedic along with an EMT, and these are going on low acuity patients, as well as they're being dispatched in a manner which it is for service calls to provide the service to the community that will decrease the amount of responses that a 4-person company would need to go on. And so those that have a smoke detector that may need a replacement battery or leaky hydrants and so forth, we were able to send a 2-person deployment as opposed to sending a 4-person ALS company. These community paramedic units also do a lot of treat and refer, so they'll take care of patients on scene as they evaluate those individuals and can get those patients to a primary care provider or to another healthcare resource. And that is an important part of that as well. We keep these patients away from emergency departments. The community care units that we have that are responding is with an advanced practice provider. Then currently we use a nurse practitioner for that model, and it is staffed with not only the community care unit is staffed with a captain paramedic with the Mesa Fire and Medical Department, as well as with an advanced practice provider who is employed by Mountain Vista Medical Center. As we have brought these two parties together, They respond and are deployed in this 911 model on the lower acuity patients, and they're treating and referring those patients back to their primary care providers. They can also provide for alternative destination transport and also have a 24-hour follow-up care for all patients that have been seen. As an example, a person may call 911 because of a laceration to the forearm. That laceration the bleeding could be controlled, and the deployment model would be for a two-person response. That two-person response would actually include the firefighter captain along with the nurse practitioner. So that community care unit responds to the scene, will actually evaluate that patient. They'll be able to numb up that laceration, close it with sutures, give the person a tetanus shot, give them a prescription for antibiotics, encourage the patient to follow up with their primary care physician in 3 days with stitches out in 10. This keeps the patient away from the emergency department, which is an increase in cost or expense. And we can manage the cost of health care much better by managing these patients in a much different way. This deployment model currently is going in peak time, and so we've been able to identify that those times are between 9 a.m. and approximately 9 p.m., and that's the deployment model that's being utilized today. With the CMS grant, these units will be up and running 24/7, which would be a wonderful opportunity for us to decrease the amount of dispatches for ALS companies and deploying a more appropriate level of care to patients that are lower acuity. And that's going to be an important model. Another component that's going to take place with this is medication reconciliation. And so as we go out on patients, in particular the elderly patient with polypharmacy, we'll be able to review that patient's medication history and identifying which medications may show up on a Beers criteria, which would be medications that are not indicated for use for the elderly population. And as we are able to identify that, communicate that information back to a primary care provider or the prescribing physician and see if there's an alternative that could be provided to this particular patient, thereby decreasing the number of fall injuries that we actually go on. And we believe that will help out substantially, as it has been proven over the past 2 years. We are also identifying a need to have a nurse triage system inside of our dispatch center. The Mesa Fire Communication or Call Center will be able to receive those 911 calls in a traditional fashion, having an emergency medical dispatcher answering that call and asking the questions of the caller, and then to make a decision based upon what needs to be deployed. An example could be a person that's a non-breather is an easy dispatch, because the deployment would be send out a 4-person ALS company that would allow for advanced services to be provided immediately to take care of that emergent patient. Those patients that would be calling upon a lower acuity, that call would be transitioned to a nurse triage, where that nurse would be able to ask additional questions that would actually cause that patient to come down to a point where it is the lower acuity model would be dispatching out either a community paramedic, could be the crisis counselor, the advanced practice provider, but some component of a lower response than a 4-person ALS. If a 4-person ALS response is still required based off of the nurse triage, then that is still at their ability to dispatch out that particular unit. So we'll have multiple units available for that kind of dispatch, where we will send the most appropriate unit to the most appropriate call, so that the highest quality of care that the person would be needing is going to be provided by those care providers that are on scene. The Community Care Behavioral Health Unit is currently staffed with a captain, firefighter, paramedic, and a crisis counselor, and they are dispatched primarily on calls that are engaging with those individuals who are of a mental health nature. Many times there's a police officer that is involved in those kinds of dispatches, and so we're able to get on scene and help to minimize the number of officers that are required to be on scene, because a crisis counselor can help to facilitate the behavioral emergency that may be taking place at that time and get more appropriate transport to a facility, to a behavioral health facility where definitive care is going to be received. We don't take cardiac patients to stroke centers. We don't take stroke patients to trauma centers. We take those that are of a cardiac alert type of patient to cardiac centers, and trauma patients to trauma centers. Hence, we should take our behavioral health patients to behavioral health centers, where it is that they can receive that type of care. We find that those behavioral health patients that are taken to a emergency department, we find that the cost to care for those patients is much higher. However, if there is a medical problem associated with that mental health patient, then the most appropriate care is going to be received in the emergency department, as opposed to going to the mental health facility. So we have to make good medical decisions as well as mental health decisions with our behavioral health unit. And this is going to become quite important. An example of this is on a community care behavioral health unit call, 911 was dispatched at approximately 1300 hours with the Mesa Police Department for a patient who had self-inflicted wounds to the arm. And as arrival on scene of the police department, there was a request to have community care mental health unit to respond. That community care mental health unit was able to diffuse the patient situation, call for the community care unit with the advanced practice provider to come out and care for the laceration, and then transitioning that patient back to the behavioral health unit to go to a mental health facility. That definitive care was then received at 14:45 hours. When you consider that call lasting for an hour and 45 minutes to take care of one, a medical issue, and two, a mental health issue, and to get them to definitive care, that patient traditionally would have been placed into an ambulance, taken to an emergency department, where it is that the laceration would have been repaired, and the patient would have received a mental health evaluation, but then would have been kept in the emergency department for days, at which time the patient would then be transferred over to a behavioral health center. The typical time frame of holding a patient in the emergency department for mental health reasons is approximately 3 days. Sometimes it can be as long as 2 weeks. We find that that is a poor utilization of resources, and we would prefer to have those patients managed in behavioral health centers. Of course, unless it is that there's a medical condition that would require them to be in an emergency department. In January 2013, we invited Fox Channel 10 to come out and ride on this unit.
Locations. Let's talk about things that work. This is working. The Mesa Fire Department getting some national attention for a program that began back in August. It's an idea to help with overcrowding in emergency rooms. Fox 10's Mark Martinez has been looking into it. He joins us live with the story. Mark.
Yeah, John, it's quite the idea. For the past 6 months, a Mesa fire captain has been teamed up with a nurse practitioner to respond to low-level emergencies. The idea is to treat people on the scene so they don't have to go to the ER, even writing prescription. It's almost like a primary care provider. It looks like just another ambulance, but think of this more like an urgent care on wheels. Mesa Fire Medical teaming up with Mountain Vista Hospital, pairing up Fire Captain Brent Burgett and nurse practitioner Tom Morris to respond to low-level emergencies.
It's probably a lot more cost-effective to do something like this than it is to hire more people in the emergency department and to expand emergency departments.
We went on a ride-along today to see the team in action. This man called for help after hurting his back while pushing a car.
I'm going to get some vital signs. I'm going to put some ice back there, and we're going to get you something for pain, okay? Sound good? Yeah. Right on.
After about 20 minutes of treatment, the man was able to walk out of the ambulance, avoiding a trip to the ER.
As a nurse practitioner, I'm able to go into patients' homes. I'm able to go onto the street, the places where emergencies happen or urgencies happen, and deliver care there as opposed to in the hospital emergency department.
And it also frees up the other firefighters to respond to more serious calls.
Cardiac arrest, strokes, all the very high urgency calls. These engines and ladders are going to be available because we're on a low-level emergency that they may have been tied up on.
And nearly 80% of the department's calls are for medical cases. Fire departments from other states are now looking at this program to see how it works. The city will test this program out for about a year and then evaluate to see if it will become a permanent setup. Reporting live, Mark Martinez, Fox 10 News.
Here you can identify who our CMS partners are within the grant. And so, of course, sitting as the big umbrella component of this is CMS. That's the Center of Medicare and Medicaid Services. That is where the $12.5 million grant is coming from. And then you can see that the partners are listed below with Mesa Fire Medical Department. That's in the center. And to the left, Mountain Vista Medical Center and CPR, which is our behavioral health organization that's giving guidance and assistance to the behavioral health components. To the right, you'll notice that it is Superstition Fire and Medical District, Queen Creek Fire and Medical Department, which is Queen Creek Fire and Medical Department is functioning more in the capacity of an observer at this point. They are one of our partners where it is that we would provide mutual aid, where we would provide automatic aid to them, as in A.T. Still University, which is providing a lot of our education that will be received not only by the captain, firefighter, paramedic, but also by the advanced practice providers. There'll be a 40-hour training that will take place for both of them independently, as the instruction that we receive by the firefighters is different than that of the advanced practice providers. And so those educational components have been developed, and the curriculum will be presented to those that are selected to work on these units. The organizational structure is as outlined in Mesa Fire and Medical Department, and there's medical oversight and project management, as well as a legislative liaison, and then you can see the others that are down below that. Of those partners, you'll notice that Crisis Response Network and CPR and Mountain Vista Medical Center is who it is that we have collaborated with so that we could best design a model in which it is that we can deploy the most appropriate resource to the individual who's making that call. We have found that these partners have given us a great deal of guidance and assistance. They've been helping us with billing services, with data collection, and reviewing our patient outcome measures as we are in the process of developing those. Currently, there is no national standard that is based on the out-of-hospital care provider in the 911 model, and we are assisting in its development of patient care outcomes. We look at operational and jurisdictional expansion of the CMS grant to other jurisdictions, such as Superstition Fire and Medical District, Queen Creek Fire and Medical Department, as well as entering into those arrangements with hospitals so that we may better care for those patients that have been hospitalized, discharged home, that we may see them in the first 72 hours of discharge, so that we may not only just review their hospital course through their discharge summary, but also review their medications. So we do medication reconciliation, do a home safety inspection, both inside and outside of the home, and provide guidance and assistance to the individual and family and caregivers so that the patient is best cared for. This is only to take care of gap coverage. This is not for us to get into the home health business. This is exclusively for us to help manage patients prior to them getting involved with either hospice or home health care or other ancillary services. We will just provide those gap coverages, which we believe is very important. The communications center will take care of the nurse triage and also schedule calls. So there's non-scheduled calls of 911, but there's also the scheduled calls. Those scheduled callers will speak with the nurse, and that nurse will take care of scheduling those appointments for the following day, which will help out substantially. Another part of what it is that we will be doing is centralized medical direction. In our current model, paramedics, if they're on scene and they have questions about patient care or even destination of a specific patient, they call to the base station, which is a hospital, which many times it's a nurse intermediary that picks up the phone, transitions information to the physician, and then comes back to the paramedic. And oftentimes it is just bring the patient to us, we'll evaluate the patient when they get here. And very little information or advice is provided by a physician. Using centralized medical direction will afford the paramedic or any of the advanced practice providers or crisis counselors or community paramedics to call up through a 10-digit number that will be recorded in the call center and go out to a physician. The physician will pick up the phone in 3 rings and will also have a tablet by which it is they can see the information that the pre-hospital care provider or out-of-hospital care provider is obtaining, and they'll be able to see a 12-lead EKG, they'll be able to see an EEG, they'll be able to even be Skyped into a scene where it is they can say, here is a patient, and this is what the patient looks like, or if it's an accident scene, they can also hold that up and say, "Doc, here it is, take a look, this is what the scene looks like." And so the physician is able to participate in a better decision-making process because of that information as it comes. And what we'll find is we'll have an improved medical advice being provided to those individuals who are on scene caring for those patients. We believe this will help us to enhance our research and as well as our reporting capabilities as we are developing core measures and patient care outcome data will drive much of those core measures so we can actually look to the future. Currently, our model, that as we take a look at low acuity patients, that we are called through the 911 model, and the patients are evaluated by a 4-person ALS company, placed into an ambulance and taken to an emergency department. That current model demonstrates a very expensive cost to the healthcare system. You can see on the left where it speaks about the past model. You can go through and add those up. Our newer model, you can see really what the cost is associated with that. It's approximately $525 total in order for us to manage that patient. And you can see that the savings that would be realized is over $2,650 per patient of a low acuity nature. And that is a substantial savings to the healthcare system. When we do the same comparison, looking at those that are of behavioral health nature, we see a potential savings per patient in excess of $11,000. And so $2,600 for a medical patient, $11,000 for a behavioral health patient, that's a significant savings when we go back and remember that 11% of our calls are for those patients that are of a behavioral health nature, and of the lower acuity type is approximately 25% of those total calls. And so you can do the math, and you'll see that last year in the city of Mesa, we've been able to save in the healthcare system $4.3 million, which is a substantial savings to that system. The type of insurances that we were able to collect in 2013 for the community care unit that was the advanced practice providers, you'll be able to identify that a majority of those patients were covered with healthcare insurance, whether it was Medicare, Medicaid, or private. And on the behavioral health side, it was 80% of those patients that actually were insured with either Medicare or Medicaid. And 19% of those patients had private insurance, with only 1% of them having no insurance at all. And so we find that the mental health patients, these individuals are actually covered at a much higher rate than those without mental health problems. However, a majority of these patients are covered with health insurance. And for those that are not, one of our goals is to actually help them get onto health insurance so that the healthcare system as a whole gets compensation for the services that are being provided. We feel that is also an important piece. There is a community outreach program that has been also created. It's called the Prevention Action Line, and that is a partnership with Crisis Response Network. And the Crisis Response Network is one that has takes emergent type calls on a 10-digit number, and they will help to coordinate the services or care that a mental health patient may be in need of. So these are individuals who have not called 911, but they called a separate landline in order to receive assistance. We are working through that preventive action line to go out and evaluate these patients just the same, whether it is that it's a fire response or whether it happens to be a secondary response that Crisis Response Network has identified will be determined. But we are still in the process of working through all of that. There is also something that is referred to as the Loyalty Customer Program. This Loyalty Customer Program are those that are frequent visitors of the emergency department or callers of 911. So in working with our hospital partners, we're able to identify those individuals that may come in by private vehicle to the emergency department or by ambulance to the emergency department. And we can identify them, go out and see those patients, as typically there are patterns of behavior when these individuals call, and go out to see them much sooner. And that's going to be an important piece. This, we believe, will reduce the number of EMS calls that we receive, as well as the visitors to the emergency department. And we'll be able to work directly with our regional ACOs, as well as high performance network healthcare systems. And as we work together with them in partnership, we'll be able to identify these patients and work with them in a different way with use of social workers or nurses or community paramedics or whoever that needs to be. That'll be dependent upon who that person is as we identify what resources are truly necessary, whether they're community resources or healthcare resources. We'll be able to get them away from the emergency department. We also believe in a robust immunization services, and all of our paramedics in our systems, whether it's the Mesa Fire or Superstition Fire, are all shot techs or immunization technicians. Each one of them is able to provide immunization services to the public, and so in partnership with Mesa Public Schools, annually there are 11,000 children who are immunized through that system, that program. The community-based immunization clinics have administered an additional 3,000 immunizations to adults and children, and that includes a flu vaccine and all other vaccines that are required from our children. The home safety inspections and fall prevention program is well underway, and that is in doing home safety inspections so that we can assist homeowners or residents of homes to be certain that there are minimized fall risks, as well as doing fire prevention in that home, doing medication reconciliation with our community paramedics and or advanced practice providers able to perform those services. And we can also bring in social services as necessary, and that will help benefit the public as a whole. The transitional care program we've discussed briefly, but it's about a 72-hour post-discharge follow-up. We have found that patients that are discharged from hospital, many of them being elderly, are discharged with multiple medications. A patient may have called 911 for a concern, and they were taken to the emergency department, admitted to the hospital, and may have been on 10 medications at the time of admission. 5 of those medications may have been changed. Now when a person is discharged, they go home to seeing their 10 medications to which it is they were taking once before, with the addition of another 5 medications, and now a person's looking at 15 medications and may not know what to do with those medications. And we believe that doing a medication reconciliation with those patients, helping them to understand that they are to discontinue these 5 and only take now the 5 that they were added to, so now still a total of 10. And we can communicate that information back to a primary care provider or cardiologist, pulmonologist, or whoever is the prescribing physician of that particular patient. So that medication reconciliation does become quite important. We will enter into partnerships with various specialty providers, and so those will be physicians who will be able to assist, such as nephrology with patients who are on dialysis. That will help them tremendously in managing those patients in a much different way than they've ever done before. We believe this will reduce hospital admissions and be able to retain a significant amount of savings in the healthcare system and helping offset the cost of care. These are our goals, and that is to respond to the rising costs of healthcare, deliver a higher quality service of healthcare, and as we're doing so, get the right service at the right location at the right time, and entering into more fiscal efficiency. And overall, it will best balance the cost, quality, service, and cost recovery to make these programs sustainable. Thank you for your time. Everything that we're involved in right now is really to answer the Affordable Care Act that was signed into law in 2010 by President Barack Obama. And that is, it's really threefold, the triple aim of the Affordable Care Act. And that is to improve the quality of health care that's being provided by the healthcare community. Second is to have increased accessibility of health care to all citizens. And third is to have a reduction in cost. This is a way for us to actually manage that.